Good afternoon, everyone. Yeah, so it's my great pleasure to introduce the next speaker, who is Dr. Teo Kejia. Yeah, I think Dr. Teo is a neurosurgeon in our Department of Neurosurgery in NUH. Yeah, and we sent him to train with Professor Dufault, whom you heard earlier before lunch. Yeah, so we are essentially an awake surgery center that follows many of the principles of awake surgery as espoused by Prof. Dufault. Yeah. I think, as was mentioned in the previous lecture, I guess for many people, when we talk about brain tumors, for a long time, I think brain tumors were at least malignant brain tumors were a bit different from other tumors. We never talked about margins, let's say, well, like in skin cancer or colorectal cancer, because the brain was felt to be very eloquent. But as Professor Dufault showed you, with exquisite brain mapping, you can actually map so many of the cognitive functions. So in some cases, we can actually go beyond the margin, and we try to get margins, so to speak, for the first time in surgical neuro-oncology. Yeah. But in some cases, as Prof. Dufault also showed you, we're not able to take out all the tumor because vital cognitive networks still exist within the tumor. And we've got to come back 3-4 years later when the phenomenon of neuroplasticity occurs and the networks are shifted outside the tumor area, and we can come back and resect it again. So these are all paradigm shifts in the way we have treated low-grade gliomas, and as Prof. Dufault has shown, that's really changed the natural history of this disease, which, while uncommon, it unfortunately affects young people. So I think here in Singapore, I think Dr. Teo has gone with a team, the PhD neuropsychologist, Dr. Chan Hui Min, to train, because neuropsychology, as you can see, is a very important part of the workup of these patients before and during the surgery. So, and the challenge in Singapore is because we are multilingual and multicultural. So Dr. Teo will give us a walkthrough about how he does awake brain surgery in Singapore in a very much more challenging environment than a monolingual, monocultural country. Kejia, the floor is yours.
Yeah, thanks, Prof. Prof, you also played thank you. Also played a pivotal role in my training. I'd like to thank the organizing committee, especially Prof. Jimmy So, for letting me have the chance to speak in this symposium. And it's always very difficult to speak after the giants of neurosurgery, Prof. Dufault, but I'll try my best. So today, I'm going to talk about awake brain surgery and brain mapping, and how we do it in Singapore. So it's a bit different because Singapore, it's a multicultural and multiracial country. And just to show everyone how we adapt our tasks and our expectations from brain tumor surgery in general. So there's a... Next slide. Oh, sorry. Yeah. No, back. Go back. Okay, I'll do it. Okay, got it. Okay, so there's a mixed group of people from different specialties in the crowd. So I'm just going to start off with a few slides on the different various brain tumors we encounter. One of the most common brain cancers we encounter in the world is secondary brain cancers. So there are metastases from elsewhere. What I'm going to focus about today, in addition, is primary brain cancer, in particular gliomas. And they all start off being low-grade first, and they progress subsequently to grade 3s and grade 4 glioblastoma multiforme. This is a very important tumor because, as you can see, it affects people typically on the age of 30 to 40 years at the prime of their life. It's increasing in incidence, and they do affect not only quality of life, but the overall survival of our patients. So when I was a trainee, this was how we diagnose a glioma. It's through the eyes of a microscope, whether it's astrocytoma, oligodendrogliomas. Times have changed with molecular diagnosis, discovering IDH status, MGMT, 1P19Q. And so there's a paradigm shift in how gliomas are graded. And so what's initially thought to be low grade, within low grade itself, there are also some have higher incidence of recurrence, higher chance of turning malignant into a malignant glioma. So it brings us back to the question, why do we need to treat primary brain tumors or brain cancers so early? Because we know that now that they're continuously growing, they cause epilepsy, and having seizures and epilepsy can really impair a young person's quality of life. Imagine if you're 20 to 40 years old, you're at work and you keep having seizure every week. So this is a problem. And we all now know that with certain molecular markers, they will eventually become malignant cancers, and they'll be too late to treat such patients already. So from the beginning of time, low-grade gliomas, when I was a trainee, when I was working in London, what we used to do was we used to either biopsy or we watch such patients. We don't do anything until eventually they start growing on repeated MRI scans, MRI perfusions, then we start going in. But we know that that's too late. So what we do now is based on all studies that if we resect them early, we can increase the median survival. Now this is for low grades, that means the grade 2s. And like what Prof. Dufault said earlier, the overall survival for just a simple biopsy and chemoradiotherapy is 6 to 7 years. Just by doing surgery alone to resect them early, you increase it to double. But now his data is up to 17 years. And this is without chemotherapy, without radiotherapy, just by complete excision or supratotal excision alone. So besides low-grade gliomas, this rule also applies to grade 3s. Grade 3s are slightly higher grades than the grade 2s. That early resection does make a difference to the survival and the overall survival. Now, how much do we resect for each brain tumor or brain cancer? So this paper clearly broke down the extent of excision. So as you can see, the more you resect from partial, subtotal to supratotal, you make a significant impact to the overall survival and also to the quality of life. So if we continue on to malignant brain cancers like glioblastoma, having a very large area of excision, supratotal excision, beyond the margins you see on the MRI scans, also does make a big significance to the overall survival. So I mentioned a few terms earlier about total, subtotal, supratotal. So what does it mean in the realms of neurosurgery? So if we resect within the tumor, where it's supposed to be safe because you don't touch other parts of the brain, it's what we call a partial or subtotal resection. If you resect the margins of the tumor, it's what we call total resection. And if it's outside the tumor, it's supratotal excision. So this is what we are trying to advocate. So how can you have a supratotal excision? How can you remove brain cells that have got no cancer? Well, patients have problems. It's not right. But the only way we can do about going this is by doing awake surgery or brain mapping, and that's on real time. We can assess the brain functions of the patient as we resect the tumor, and we'll be very sure how we leave patients intact without any problems, or whether physical problems, neurological problems, or even neurocognitive problems in future. Because bear in mind, the majority of these patients are 20 to 40 years old. They're all our age, or younger than us. So even on the literature said that with general anesthesia, 15% of them get post-op deficits, and with awake surgery, this reduces by 5 times, 3%. This is all published. So awake surgery is not something new. It's actually been there. If you do a PubMed search, it's been there since 1975. And the earlier papers were all talking about how do we administer anesthesia to do awake surgery. But as you can see, since the late 1990s until now, there's been a large surge in interest and in research on awake surgery. How do we perform such surgery? And majority of them are on brain tumors. And in Singapore, it's no different. So in the early 1990s, I think Prof. Yeo and Dr. Lee also performed the first few awake surgeries in Singapore. And I managed to dredge out this very old article in 1991 on how awake brain surgery was performed in Singapore. So when I was reading this, one thing interesting, if you look at the comments of the patient, she said, I didn't feel any pain. The doctor kept talking to me, asked me what my name is and where I live. So when I started, I tried to do the same. I realized I cannot take tumor and talk to the patient. It's very stressful. I don't know what I'm talking. And we did the same thing. So that's how we did it initially. We just use a very old stimulator. It's called Ogimon stimulator. There's no proper neuropsychological assessment. So I couldn't talk and take out tumors. So I asked my nurse to talk, and she'll say, what do I ask the patient? I said, anything, just have a conversation. And my anesthetist who's trying to control the blood pressure has to talk as well. So there's a lot of problems we encountered during the surgery. And so not only that, during this period of time, there was a paradigm shift on how the brain functioned. Like what Prof. Dufault mentioned earlier, is a meta-networking theory of brain, and there's this theory of how do we maintain onco-functional balance. not only quality of life, but the oncological balance of patients. And there are new pathways in the brain which we understand on how language works. So if you remember in med school, we used to learn about Broca's area, Wernicke's area, and one arcuate fasciculus. It doesn't work like that, and this is how it works. This is how we process language, and this is how we speak. So it's not so simple as one track, but it's actually a network. And on top of that, there's this concept of neuroplasticity, of how having a brain tumor and how having surgery will stimulate the brain to form new networks in the brain so that we can go back in and resect again, and how we can push boundaries as we resect tumor while preserving all these tracks in the brain. And so that's how we did it. We learned from all these papers, we went to different institutions, and we started setting up a team, which Prof. mentioned, consisting of neuropsychologists, a neurophysiologist, which is important as well, our rehab team, and our oncological team. Yes, so we became very selective in our patients as well, comorbidities. We can't just do it on any patient. And all of them need to undergo strict neuropsychological assessment. And we do it mostly on cancers and even benign brain tumors, or even non-tumor conditions like cavernomas or vascular malformation. The ultimate goal of doing brain mapping and awake brain surgery is to maximally remove the tumor while minimizing the risk to patients. It's not for the following: very young kids or those with decreased level of consciousness, you cannot monitor anything, or patients with obstructive sleep apnea. This airway becomes a problem. And we can't perform that. All our patients have to undergo neuropsychological assessment. So in the past, what was considered successful was when the patient can wake up, can say their name, can move their hand. That's not enough. So all our patients have to undergo a strict neurocognitive assessment to make sure that their scores are okay or even better after surgery. And they need to go for training for certain tasks for them to perform during surgery. Because whatever task they perform in the theatre will not be the first time they are doing it. So any errors they make during surgery are true errors, and it's not because of them not being familiar with the task or fatigue or what. So that's how strict we are in collecting our patients. And this is just an example of a neurocognitive score we do for every patient who's going for brain surgery. We do a MOCA score, attention, even emotions, memory, language. All these have to be tabulated and scored before surgery, and we monitor this after surgery as well to see any improvements. So we were all good to go. We thought we could do this, but we had a bit of a problem. One of the problems is Singapore being a multicultural, multiracial. There's more than one language, so that certain rules cannot apply in Singapore. Perception in Asia, having to have their head cracked open and perform tasks while someone takes out something from my brain is considered barbaric to them, and it's scary. So these are certain hurdles we have to, to meet, to cross in Singapore. So like I mentioned earlier, neuropsychological wise, having a multilingual patient is not easy for us to perform such surgery, and we're talking about Singapore alone. Sometimes we have patients who migrated over to Singapore from neighboring countries, Indonesia, or even Vietnam. So language becomes a problem, and we need to get the help from translators. So we try not to do with a translator because there's a lag between the patient's response and what the translator tells us. So these are the initial problems we had, and of course, Singaporeans are very emotional people. We got a problem with acceptance, and there's a stigma. Nobody wants to be known that they're seeing a psychologist because either in a job they say that you're crazy, or they got a psychological problem. So this is one of the problems we have, and insurance doesn't cover this. So that's one of the big problems as well. We had to adapt, and one of the first few things we adapted was our naming task. We changed it to have a more local flavor. So instead of having borrowed tasks from our countries that we learn from, we started developing our own tasks. So we have this example of a naming task in various languages. And thankfully, my team, a lot of us can speak different languages without the help of any translator. And also pain threshold. Pain threshold is something that is also very important. I realize that a lot of Singaporeans, maybe a lot of us get a lot of discomfort from surgery, and we got special equipments. Like you can see, there's a padding underneath the patient. It's supposed to be a special air foam which molds to the shape of the body and makes it really comfortable. I tried lying on it without my brain open up. So this is comfortable for them, so that they can perform all their tasks very safely. And cost is a problem as well. So instead of having a high-level intraop MRI, intraop CT, we use pretty basic stuff. This is what Prof. Dufault does as well, just by simple stimulator and QSA when we need it, ultrasonic aspirator, and just bipolar and a sucker. This is just an example of the electrical probes we use to stimulate the brain. A bipolar probe, which gives low-frequency stimulation to the brain. A monopolar probe for us to get high-frequency train of fire stimulation to the brain. So patient will perform certain tasks, and we start stimulating the brain. So our techniques of how we do it, but once we wake patients up, we start stimulating the brain with a high-frequency probe. And so on top of real-time feedback, I also use a neurophysiologist. Just in case patient cannot tolerate the procedure, I get EMG and get SSEP, MEP to give me insurance in case something happens during the surgery. And we start waking the patients up. And we start doing a wake mapping for language or other non-language tasks. Based on our experience, actually, in Singapore, our patients are actually quite hardy, so they can stay awake for up to 1.5 hours. Anything more than that's a bit dangerous because they get fatigued, their attention span starts dropping, and they start making errors, and we'll stop the surgery prematurely. So we have this small, it's quite a large window, 1.5 hours to remove as much tumor as safely possible before putting them to sleep. Languages, because of this 1.5 hours, we do not. The thing unique about Singapore is we have to map at least 2 languages because most Singaporeans can speak 2 languages. And a lot of them want to preserve 2 languages. So we have to test whatever thing in 2 times in 2 different languages. And we do it in 1.5 hours. And we need to be careful of seizures because overstimulating can cause seizures. I'll just very quickly go through certain tasks we do. I just want to show everyone. So one of these motor tasks we do is on Praxis. In the past, testing motor power was just this, but people found out that even though they can do this, but if you give them a pen, they cannot write. If you give them a key, they do not know how to put it into the door. You show them a doorknob, they do not know how to open. So Praxis is actually the ability to perform complex tasks. There's only 2 people in the world, only primates and human beings can do this. It's motor cognitive tracks. So we have to think and do it. And so we test this during surgery. How do I play? How do I play? Can I play this video, please? And I just want to show you how we test during surgery. So she is performing motor cognitive tasks, and I'm stimulating the brain. As you can see soon, she will get an arrest there. You see? She stopped doing it. That's because we're near this track. This is a motor cognitive track where they cannot do certain tasks. And this is just an example of certain things we do. I'll just quickly go to language as well. The main problems with language is, like I mentioned, at least 2 languages. And languages are very important, whether is it ideographic, pictographic, alphabetic, or phonetic. So these are all very important aspects of language. It's not only the left side. So it's not only left side where they can speak English, but no, a lot of us can speak 2 languages. And that's why I just want to show you that even for right-sided tumors, we do them awake. This is just an example of the lady. Can you play the first video below? The lady, the first day after surgery, on a right-sided tumor where most people will do them asleep. But I see when she woke up after surgery, okay, now it's fine. Yeah, she cannot speak. You know, she's got latency in her speech and everything. But it's right side. Why is there speech? So we did find out that actually there's a lot of right-sided hemisphere representation for our second language, be it Mandarin, Tamil, or Hindi. And so this is just an example. And 3 months later, she could speak normally. Why? Because of neuroplasticity. I'm sorry, I can't show you the video, but it's fine. Let's move on to the next one. And also for bilingual, I wanted to show you this young girl. She's 28 and she's got a brain cancer, and we could show you very nicely that she could actually speak in English, and she could switch to Cantonese, and we have to map switching of languages as well. I can't show the video. Huh? But there's no sound.
星星呢個係星星樹，你要講呢個係呢個係樹，呢個係蠟燭，呢個係瓜。Can start, Kejia.
So for example, I just want to show everyone this higai. Basically, this is. So for example, for the non-neurosurgeons here, so we are quite strict. So naming problem is when you ask them to name something, so they say this is a dog. So when if a naming problem, they say this is a, they can't name. A speech problem is they can't even say this is. So that's how we, for example, how we test language and naming. So we do the same for our patients in Tamil and also in Hindi. That's unique in Singapore because a lot of them can speak 2 languages. And also, we also did a study on multilingual patients who speak more than 2 languages, which is unique to us in Singapore. Okay, so besides language, there's more to the brain than just speaking and moving. So there's this thing that we also map non-language tasks like spatial awareness. So spatial awareness is something we take for granted. For example, driving, we need to know where we are, and that's what we map as well. Even for the right parietal lobe, the line bisection task, that is what we do. And also executive functioning. So just an example, this is a Stroop test. You can try this. I'm not very good at it. But, so you're supposed to say the color and not say the word. So the first one is red, the next one is green and blue. So patients have to learn this before surgery, and during surgery we test that and we start stimulating is this a right-sided right eye for right frontal striatal tract as well? It's for executive functioning. And we need to pick up certain errors. But a lot of people, although they speak English, a lot of them are more comfortable with other languages, and we have to adapt. We have to change to the Mandarin version in Singapore as well to test that. Emotions. Yeah, so this is a bit of a thing that we're doing in Singapore as well. So there are some patients who had so-called successful surgery, but if you realize they're just not their normal self, they're not there, even though the surgery was successful. And we realize that actually the reason why they're not there, sometimes they just can't recognize emotions. Having emotions is what makes us human. We're angry. Can we recognize anger? Can we recognize sadness? And so this is a test which we do. It's called reading the mind in the eye, that we try to reciprocate here in Singapore. But that's a problem. I realized that all my patients fail that, and I was a bit angry. I tried it myself, and I looked at these 4 sets of eyes, which is a standard test that we do. Can you tell me which one is happy? Yeah, so we can't. Yeah. So, yeah. Okay, maybe you're better than me. I got emotion problems, but anyway, I couldn't. So I realized it's persistently we have a problem here in Singapore, and so we started to adapt. We started finding why, and I realized it's the eyes. It's just that imagine that versus this. This is a lot easier for our culture. So we started developing our tests, and we are currently in the process of validating this before we start rolling this not only to Singapore but to Asia as well, on how we recognize emotions as we perform such surgery. So this is our experience. This is our old data for 4 years, which we published, and during that time, a lot of them do wake up with deficits. 100% is because we push the boundaries. We cause some temporary deficits and they get better after that. And more importantly, majority of them met the onco-functional balance. So it's not about oncological balance, but it's oncological and functional balance, quality of life and survival, not only by survival alone. Lastly, I will just quickly talk about acceptance to awake surgery. I mentioned earlier that there's a problem with acceptance. We started doing a survey just to find out how patients feel before surgery. And as you can see, there's a lot of fear, hesitancy about such surgeries. And they're all young patients. They all can do PubMed search themselves. They can go to YouTube themselves, and they scare themselves even more. So we do proper counseling, and you can realize that actually it's not so bad. And in fact, after surgery, a lot of them are willing to undergo a second surgery. This is important because this is a life, we have converted this so-called terminal disease to a chronic disease. They will require more surgeries down the road, 5 years later, 10 years later. And so this is important that they are accepting to it and not just go for palliative chemo and RT. In conclusion, I just want to say that brain mapping is the gold standard to have a larger extent of resection and to maintain oncofunctional balance, so much so for gliomas, because the extent of surgical resection changes the natural history, impacting on progression-free survival and overall survival. And the challenges we have in Singapore is cultural and language-wise. We need to adapt our tasks. When I first started, nobody knew what the symbol on the left was, nobody. But everybody knew what the durian was. So my point being that we need to adapt our tasks in the more local context instead of just following what everyone else do. These emotions, nobody will know. We need to adapt. Neuropsych assessment, educating, letting them be aware, like Prof. Dufault spoke about screening as well, which we are trying to work towards, and letting them be comfortable and more assured. We have started having our pamphlets for our patients, for them to read more instead of going to WebMD or certain YouTube sites. I'd like to thank the people who made a difference to our training, Prof. Dufour and his team, Prof. Bello, and I wasn't playing in Milan and France, but I was there to learn. I'm just a member of this big team behind me. I'm just representing them. So this is an amazing team behind me that made all this possible. Thank you.
Yeah, thanks, Kejia, for an interesting lecture. I think that's very in sync with the theme of innovation and personalizing therapy in cancer. So we'll take any questions, if there are any, from the floor. Yes, Jim.
Thanks. Just one comment and one question. That I think that the work the work that you are doing actually is very important because not only in Singapore, actually many countries have immigrants, and I think whatever you discover and the innovation you apply to many countries. Even the country in Sweden, they have a lot of immigrants. The both languages are equally important for those populations. And my question is not so on the surgical part, it's more on the biology part. So in the first few slides, you say that low-grade glioma, some of them will progress, some of them don't progress. So do you think that there's any predictive factor or biomarker to predict actually which ones we are more indolent, which one actually need more treatments?
Yeah, sorry, maybe I missed. What I meant was that they all will progress but at different rates. So eventually they will all grow. So there's a few markers like IDH markers. They kind of tell you normally the wild types are worse. And also we also do volumetric analysis. So they're supposed to grow 1 to 4 millimeters a year. So if you chart the growth for those who don't want surgery, if the growth changes exponentially on follow-up imaging, it's gone 6 or 8 mm. That's when we start telling patients, look, you better get it out.
So for imaging and
yes, so it's imaging and for those who don't want surgery, will be imaging. For those who have surgery. A biopsy, it's just the markers.
IDH. Yeah.
Yes.
Thank you.
Yes, bro.
So maybe I can ask a question. So coming from a different spectrum, coming from a breast perspective, when I started to train, because it's a matter of margins. So in the breast, we can have ample margins or no margins to play with, and in the brain, you're limited by the size of the brain. So we've gone from 1 cm to 7 millimeters to, at the moment, it's not touching the ink, which is the accepted margin for breast. So, and in this scenario, how do you deal with margin assessment? Because I understand that you call it a supra. So how do you deal with margins, not taking enough but not enough, etc.?
So thanks for the question, Prof. So what we do, we excise to physiological margins, so till the patients start having errors. And so if you reach the physiological boundary, and if there's still tumor left behind based on the post-op scan, we either wait for plasticity to happen, whereby the tracks shift away and they're no longer eloquent and we can go back and take that again, or we just give chemotherapy.
I see. And for the plasticity to happen, what's the time duration we're looking at?
So there are even papers that say plasticity happens on the very moment as you're excising tumor, the brain will start actively get networks elsewhere. But in general, we be up to 6 months or so, 6 months to even a year. So I asked Prof. Dufour earlier on, they wait up to 1 year as well.
See.
But sometimes when we stop early, it's because of due to vascular margins, like the anterior perforate substance. Near big vessels in the brain, we have to stop there. So for those, we don't wait for plasticity, we just send for chemotherapy.
Okay, thank you.
Yeah.
Okay. Any further questions? From our Zoom audience? No questions. Yeah. Okay.
Thanks.
Thank you, Kejia.
Everyone.
I think we'll move on to the second speaker. Thank you.